Starting shortly. Hello, Dr. Francois.
Hi.
Thank you for joining us.
So I think it's the time.
Okay, yes. So I'll just quickly go through our housekeeping rules, then Dr. Francois can start, if that's okay.
Yes, no problem.
All right, thank you. So, this is session 1, like I said earlier. We'll be using the chat function for question and answer. Bottom of the screen, you see the icon that looks like a message. That's the chat session. If you have IT issues, also send a message to the site, the chat session. We have our IT support here. And then the session is being recorded, and then your attendance or your registration to attend is consent for recording. Thank you.
Can you give the next slide?
Sure.
Next slide, please.
Yeah, it's on the screen. Today we'll be talking on considerations for triage, oxygen therapy, and critical care, the case-based series. And like I said earlier, with us you have Dr. Francois Uwomena. Dr. Francois,
We
please
don't see
could you?
it.
Sorry,
we
did
don't
I
see
say
the slide?
see?
Yeah, we don't see. Yes, good. Yeah, you can continue now.
Sorry?
You
Can you
can
see the screen?
continue. You can continue the introduction. Now you can see the screen.
Okay, wait, we are talking on oxygen therapy, a critical case-based series, session 1, considerations for a triage. So with us, we have Dr. Francois Uwomena. Please, did I say your name correctly, sir?
Don't worry. Free.
No, please correct me.
Uwomena.
Okay. Thank you, sir. So please, could you introduce us to your panel?
We are very excited and very happy. Today is the due date to launch our program. Our program, Dr. Xavier Eco Program, Oxygen Eco Care, case basis. Today we are going to consider to talk about considerations for triage. My hub team is with apart me, Dr. Francois Xavier Uwomena from Nyarugen COVID Referral Center. We are together with Madame Liberata Rumagihwa. She's a lecturer at the University of Rwanda, College of Medicine and Health Sciences. We have also on panel Dr. Joseph Niyonzima, is an emergency and critical care physician at the University Teaching Hospital of Butare, and we're having also Dr. Venice Nkundimana, is an internist at Kibuye Referral Hospital, where also we have a wing of COVID Center. We have also Dr. Apollineri, who is emergency and critical care physician from King Faisal Hospital, which is a tertiary big referral hospital in the country. As we said today, we are going to talk about consideration for triage, and our 6-month course or sessions will be every 2 weeks. Today, we are going to talk about consideration for triage of patients. And I want to tell people, because the first time to meet, some clarification. Please We may have clarification of the language barrier. During our presentation, we'll use English, of course, but when you have a question, you can ask question in any language you need, Kinyarwanda, Chinese, German, feel free. We need our course to be so interactive, and everyone happy to be with us in our ECHO program. Next, please. My hub, in partnership with Stanford University, Project ECHO and Assist International, we are going to use resources from Global Anesthesia and Critical Care Running Resource Center with some, of course, some consideration of our local inputs as we are working in Rwanda. Next. Next, please. This I said. So as we said, these 12 sessions will be, there's something coming to the slide, please. I don't know from where what. Technical problem. Okay, thank you. Our 12th session will be case-based discussions. So the case today is, as my colleague, most of them are working as nurses or doctors at different health facilities. We are receiving cases like this, 57 years old man who presented the hospital with 4 days of weakness, chills and dry cough. The wife has been tested SARS-CoV positive 3 days ago because she's a nurse. And today at the hospital, the patient is showing to be hypoxic at 89%. So do we have to fear and we are PPE, personal protective equipment? Will you screen this patient for COVID because the wife also has been tested positive? And what will be other concern about symptoms you may ask for? And will you need to treat these patients and isolate? During the course this session, we will answer all these 3 questions with the objective of our learning session today as please. Next, please. Our learning objectives today to answer to the 3 questions with the case discussed. We have to understand healthcare providers following recommended PPE guideline. Healthcare providers must be trained in safe donning, meaning putting on the personal protective equipment or doffing, sequences for protective PPEs. Other third objective is patients with potential contagious infection to make sure are self-isolated earlier as possible to prevent the contamination to others, and also screening methods for SARS-CoV-2 to make sure that are in place in different places where we are working. And after this session, you may think what you can do in improving the place where you are. Also, healthcare providers have to recognize and diagnose hypoxemia. This is the key of this session today. Everyone will better understand hypoxemia and how to manage it. Also, healthcare providers to know that hypoxemia, be able to use pulse oximetry to triage patients who are hypoxic as the case we had. Also, we have to make sure that healthcare providers are prescribing non-invasive oxygen therapy, as we'll be discussing in details, and most appropriate devices available to your setting. If after this you find there's something not available there, this we have what we call practice changes, and is our objective, and you want to learn and also implement what you learn from here. Next, please. So you allow me to give the ball to Dr. Venus. He's going to talk about patient evaluation, PPs, how we do, how we don't, and with other content is SARS-CoV-2 symptoms and other things we have to take care when we are taking care of patients. Dr. Venus, up to you.
Thank you very much, Dr. Francois, for the good introduction. I'm Dr. Ngundimana Venus. I work as an internist at Kibuye Referral Hospital. Please, can you confirm if you are hearing me?
Yes, we are hearing you.
Thank you very much. So in this session, I will be talking about donning and taking off PPE, the personal protective equipment. So the slide you are seeing is for patient evaluation. You know the case we came to see, the 57 years patient who came with cough, hypoxia. So usually patient, when they come for the evaluation, you start with history taking, but you may find a situation where you start with resuscitation or quick evaluation and management before coming to history taking. But usually if a patient is stable in the outpatient or emergency department or wherever, so you start your evaluation using the history taking. In the history taking, there are key aspects that you have to go through to gather the information that will allow you to make the diagnosis or the probable diagnosis. So first of all, you start by introducing yourself to the patient and gaining the consent form. This make a relationship between the healthcare provider and the patient. Then after getting the consent form, you will ask a question about the chief complaint or the presenting complaint. Then history of the present complaint, how the disease started or how the symptoms evolved. Then you record the past medical histories, past the surgical history, allergies. Then you review the system to see what particular other systems might be affected. Like our patient came with mainly respiratory symptoms, but you want to know if there are no other systems that might be affected. After that, you summarize your patient history, then you record the patient's queries if they have questions or concerns, then you provide the feedback. After that, you can go to physical exam to see the signs that are present for your patient. And at the end of the physical exam, you might be having in your mind what could be the possible explanation of your patient's complaint. Then you may order the investigations. Next slide, please. So why do we need to wear the personal protective equipment? Generally, the PPE are safety equipments that reduce the exposure to biological, physical, but also chemical hazards that might be present at your workplace. So in the era of COVID-19, PPE have served a lot to protect healthcare providers against the spread of COVID infection. So the type of PPE will generally depends on the extent of the hazard that is in place. If, for instance, the hazard is like the airborne infection, or you need to do a standard procedure, so the PPE might be different. So regarding the SARS-CoV-2 symptoms, like a patient came coughing, weak, hypoxic, so you have to worry about COVID-19 and think of a way of isolating your patient, protecting yourself and the rest of the staff. So the symptoms for COVID are not like pathognomonic. They may sound like other particular illness, like usual viral pneumonia or bacterial pneumonia. Next slide, please. So the complaints for a patient with COVID-19, as I said, they might be different. One may come with cough, fever, headache, asthenia or Triage, body aches, difficulty in breathing. Next slide. So regarding the transmission of COVID-19, so it generally from one person to another, but you may get infected through like touching infected surface areas. Generally, when the affected person releases the droplets through breathing, sweating, anyone close, like less than 1 meter, when they are not wearing protective equipment, they can get affected. And when these people get affected, they go through like what we call the incubation period, the time for the disease to develop and give symptoms. Then those people may also contaminate other people, so they get in contact and are not really well protected. Next slide. So generally, the incubation period for COVID-19 is between 1 to 14 days or 2 weeks. But generally, around day 5, people may start to develop symptoms. And they get worse between day 5-7 to 13 days, where a patient may present with shortness of breath and like the timing for the acute respiratory distress syndrome or severe respiratory complications of COVID-19, they are around 12 days of after the infection. Continue, please. Next slide. Yes. So regarding the applying on and taking off the person protective equipment, there are sequences to use. So the type of PPE, depending on the body parts that you have to protect, you have the apron or the gown to protect the skin, the gloves to protect your hands, the mask or the respirator to protect your nose or airways, and the face shield. The face shield can be also replaced by the goggles to protect your eyes. So you have also the medical scrubs. You have the boots to protect your feet, and you may have the face shield as well, as I said. Next slide. So this busy slide is to show you that the type of PPE might depend on the act or any procedure or the exposure you are anticipating. So generally, when someone is giving a birth, like a nurse or anyone else, you generally don't need something to protect yourself. If you are about to suction someone's oral secretions, you need the gloves, you need the mask, and you need the face shield, because the secretions might touch your face and get infected. If you are transporting a patient in a wheelchair, you generally don't need something to protect yourself. So when you are responding to an emergency where blood is spurting, you almost need everything to protect yourself. When you are drawing blood from, like in a phlebotomy procedure, you need gloves only. And when you are cleaning an incontinent patient with diarrhea, you need the gown, gloves. I think the message is very clear. So depending on the hazard or the risk which is there, you have to choose the PPE to protect yourself. Next slide. So before addressing the key points about personal protective equipment, I would like to request the IT support team to display donning personal protective equipment. They are other for taking off or removing the personal protective. I personally
CDC sequence for donning personal protective equipment, PPE. Cover torso from neck to knees, arms to end of wrists, and wrap. Fasten in back of neck and waist. First responder considerations for an uncontrolled environment. If a gown isn't available or practical, wearing a long sleeve shirt, spring jacket, or bunker gear will provide some skin protection. Mask or respirator. Secure ties or elastic bands at middle of head and neck. Fit flexible band to nose bridge. Fit snug to face and below chin. Fit check respirator. First responder considerations for an uncontrolled environment. Put a mask on first, since COVID-19 is primarily spread by droplets. Goggles or face shield. Place over face and eyes and adjust to fit. Gloves. Extend to cover wrist of isolation gown. Use safe work practices to protect yourself and limit the spread of contamination.
All right. The previous video was about applying on the personal protective equipment. So can you please play the video on the removing of the PPE?
Gloves. Outside of gloves is contaminated. Grasp outside of glove with opposite hand. Peel off. Hold removed glove in gloved hand. Slide fingers of ungloved hand under remaining glove at wrist. Peel glove off over first glove. Discard gloves in waste container. Goggles or face shield. Outside of goggles or face shield is contaminated. To remove, handle by headband or earpieces. Place in designated receptacle for reprocessing or in waste container. Gown. Gown front and sleeves are contaminated. Unfasten ties. Pull away from neck and shoulders, touching inside of gown only. Turn gown inside out. Fold or roll into a bundle and discard. Mask or respirator. Front of mask or respirator is contaminated. Grasp bottom, then top ties or elastics and remove. Discard in waste container. Perform hand hygiene immediately after removing all PPE. Use safe work practices to protect yourself and limit the spread of contamination.
Thank you very much. I think we can go to the slide of key points in donning and doffing of PPE. And the key message to give to the audience is PPE doesn't eliminate the transmission or infection or exposure to chemical, but the goal is to reduce the exposure as much as possible. But keep in mind, it doesn't eliminate the exposure.
I think in audience, if you have any question to ask it to Dr. Veniste for clarification, and ask in any language you feel comfortable. Thank you, audience, or you can write on the chat and we will answer. 5 minutes for answering question to Dr. Veniste.
For the questions. Yes, Janvier, do you have a question? I see Janvier Gatoni raising his hand. Do you have a question, please?
So maybe he raised the hand intentionally. So also if someone can't get a voice, they may use this chat around to ask their questions. There's also another option of asking a question by writing. Dr. Apollinaire to talk about triage. So, chat. Okay. Mr. Chubahiro Bienveni is asking when we remove the inner gloves. Dr. Venist?
Yes. He's asking when we remove the inner gloves.
Yes.
Does he mean if you have like a double gloves, like two pairs? Okay. Generally, after so in taking off the PPE, the gloves are the last part or the last PPE to be removed. So when you have taken off the outer one, using like your thumb of your main hand, from inner to outer, you remove all the gloves. I don't know if I answered his question clearly.
You can use the chat if you want more clarification of the question. We have a question, Dr. Venuste, here in the chat.
Let me go through it. Eddie Mucherangao is asking if accidentally the face shield fall down while you are inside the ward, how can you get the other on the other one? I think you are generally safe to put the other one, and you are not alone in the ward or in the isolation room or even emergency room. Wherever you are, you can call for help. Like you don't want to decontaminate many surfaces. If you have photographs and only the face shield falls off, you can call your anyone who is close to bring in the face shield and apply it on your face. It's safer.
You still have other two questions in the chat?
Why? Yes. Why is it highly recommended to use N95 rather than others? So this is a big question and good question. For the N95, it's used or airborne infection prevention. Like if you are dealing or isolating someone with suspected COVID or already having COVID or having tuberculosis, you need this N95 because it offers more protection against those air droplets. But generally, if you are isolating influenza or the usual common cold, like the surgical face mask for the protection. Why in the video they use to remove gloves firstly? So in the video, they used to remove the gloves firstly because you want to do you want to come from non-infectious. You are usually your hands touching instruments and body surfaces. So the gloves or your hands are the first supposed to have more infection. You have to remove the gloves before everything, and even before the moving the gloves and the gown, you can still wash your hands. Are not contaminated. So we also received this question: is it necessary to use chlorine solution after removing PPE before turning in nursing station? I don't have experience chlorine solution, but the ones you can use is the hand sanitizer, the alcoholic one, but you can also use the water in a sink or wherever facility is in place having water to wash your hands. But regarding the chlorine solution, I will look at it and give you back the answer.
Yeah, thank you, doctor. I think the question has been answered. But the general message here, as you said, is that people don't only focus on the COVID, where they are talking about the Cavalor, the chlorine, or whatever. The message from Dr. Venice was that take care of yourself while you are working in a contagious, infectious condition, or where you can meet such patients. Just a video for PPE. So with some particularities according to the pathogen in you have like Ebola or COVID this time. And other particular germs, please take care of yourself, protect yourself, and where you are and the patient you are taking care of. So let us call in Dr. Apollinaire. So question remaining, chat them. We will answer them next. Doctor, yes.
Just the last question, it is already there. They are asking Dr. Venusti, how long should N95 be used? Just the last question.
Venusti, the last question while we are calling in Dr. Apollinaire.
Yes, please. So regarding how long you can wear the N95 face mask, I don't have the exact answer. Generally, it's a safe wear to protect yourself. If you feel weak, you may take a break if it's possible. But generally, I don't know if it's for 5 or 6 hours. What I know, it's safe. You can have it in your shift during either round or your emergency shift if you are dealing with infectious condition or condition where you need the PPE.
Okay, thank you. Dr. Apollinaire, welcome.
Thank you, everyone, for this opportunity to talk about. When we say about triage, it comes in English to sort out, but in French it says trier, which means it's like to differentiate. And then medicine or at hospital, we use triage to classify our patient according to the priority. In this time of COVID, we do triage not only to know the patient who will be having the priority, but also to avoid contamination of others. For example, if a patient is coming with a suspect with cough, and then he's sitting as you have like chronic condition, it will be easy to contaminate them.
Sorry, Doctor.
As long as
Okay.
they have like low immunity, as long as they have like low immunity, it will be severe for them. And we know those patients with immunodeficiency or low immunity, it will be difficult to recover from that COVID. Like this active triage can prevent transmission of COVID to patients and healthcare workers, meaning that if you expect someone with symptoms, it will be better to be like seen or to be isolated early to prevent the transmission of disease. Next slide. Okay, how do we do triage and screening our patient? Every country, from what health organization as the leaders of health activity in or worldwide, they are like standard operating procedure for triage of suspected COVID-19. And then regarding those SOP for triage, if you suspect someone with COVID, you have to separate so that they cannot infect others. Meaning that early identification and separation of those suspects of COVID along triage will prevent transmission to healthcare providers, to contaminate wards and where they are passing, also other patients who are coming for the hospital. We know that our hospital, they are not designed for only COVID, but we are receiving patients because they have complaints. And then with those complaints, if you suspect that it's COVID, no one will come like with a sign that this is like a true COVID, because as we know, or as we'll be seeing, the symptoms or signs of COVID are similar with other disease, are similar to with other respiratory infection. Next slide. Okay, our triage, we have to have like a clear communication and the training of our health facility staff to ensure a good triage process. If I suspect someone, I have to be aware that I can be contaminated, or my neighbor can be contaminated. So I have to cut that circle of transmission as soon as possible to stop the spread of the disease. As we know, on our triage, set up and equip our triage, all patients, it's like in most of SOPs, in most of countries, should be wear mask. And then, and to limit point of entry to control how the SOPs they are respected. Also, there is a visual alert to show people how they wear mask, like, and the precaution to avoid those transmission of those conditions. And when we talk about when there is we are in a treatment center, there is where we call green zone and the red zone. Green zone is where there is like all people who are there, they have to minimize, it means that it's a clear area. But in the red zone, everyone there have to be in a full PPE, considering what is going to do. and then to assign a dedicated clinical staff for physical evaluation of patients with COVID-19 symptoms, meaning that that staff will be in PPE to avoid to transmit to get the disease. Also triage, you have to avail all required equipment and supplies to assist in such case. For example, if you are triaging someone you are suspecting COVID, you have to be sure that I have thermometer, and then if there is a fever, I'm able to provide medication for fever. If I see that the patient has hypoxia, it will be better to be with oxygen so that you can give oxygen immediately, as long as if you delay in providing those essential medication, or if you delay in giving those essential medication, it will aggravate the condition. Next slide. Okay, as I was saying, in COVID-19 triage, there is a minimal kit you may have at triage, meaning that if you know that people who will be coming as a suspect or positive, you will be having different PPEs packages and the different size, because you know you may have someone of 100 kilo, someone of 50 kilo, and then you have to consider someone who will be doing triage, how the size of his mask, size of gloves, size of gown. Surgical mask for patients, thermometer, pulse oximeter, oxygen origin, for example, the portable cylinder, hand sanitizer, gloves to sanitize hands after each, or to sanitize your gloves after touching the patient or doing any procedure. And then you may have like a wheelchair or stretcher if the patient can't move, so that you can move from the triage area to the treatment area. Next slide. Next slide, please. Okay, as you know, our patients, considering where they are from, IPC measures have to be respected. And then our area have to be with the limitation where there is a green zone and then the red zone. Our patients of COVID may come from mass screening at the airport or international borders, or at the hospital as people coming for treatment. Those, for example, as a mass screening, the setup have to respect those green zone and the red zone. If they are doing rapid tests, they be different exit, because if they test me and I become positive, that's why I wait. And then positive, there is your area of exit. If you are negative, also you have your area of exit, so that to minimize the risk of contamination either at the screening center or at the hospital. We know that most of our hospital doesn't have like those are like design the area of triage where there is an entry and or exit, but I encourage people at their different hospital because that will minimize the transmission of COVID from people who are negative from others who are positive. Next step, next slide, please. Next slide. Maybe there is a technical, I don't know, but we can keep going. Can you hear me?
Yes, we can hear you, but there is no new slide.
Okay, we can keep going as long as there is a technical problem. The next slide was looking at the testing and the isolation of our patient. We know that we have like two testing methods that I will be explaining. You can test someone with a PCR. At that time, you are looking for COVID-19 genes. We have to look for genes to differentiate our COVID from other coronavirus, which cause respiratory disease. If all those genes, they are available or they are detected, we say that our patient or our test is positive. But when we are not seeing all those four genes, we call it presumptive results. In the case of those presumptive results, the test have to be repeated within 72 hours. After 72 hours, it will confirm either if it was COVID that it became the four genes they are available, or it turns negative or keep presumptive. And if it keeps in presumptive, you will also repeat the test after 72 hours, according to our guideline. If there is no gene present to the testing, to the PCR, at that time, the patient or someone is negative. Also, we can use a rapid test where we are testing for virus antibody or virus antigen. At that time, we have positive, there is availability of antibodies to someone who has been taken a sample, or if the antigen. If negative, meaning that there is no antigen or antibody for the virus. Also in our guidelines, you have to consider also people that we can suspect that they are positive, even if their PCR or rapid test, they are negative. It's someone who is showing radiological signs or clinical sign of COVID, even if it's negative. Next slide. The next slide regarding our presentation is the isolation of our patient when they are negative or when they are positive. We know that we isolate those people with symptoms to avoid the transmission of disease to others. If someone is negative, it's okay. If he has, we have to consider that he's negative and treat as someone who is negative. Even if he has respiratory symptoms, we may treat as pneumonia or cold. If presumptive, has to be isolated to wait those 72 hours for repeating the test. For someone who is positive, if he's very sick, our guideline said he has to be in a treatment center, but if he has like minimal symptoms, he can be observed at home-based care and followed by community health workers or health center nearby the patient. Next slide. As summary of our triage, isolation, and testing, when you are at the hospital and you see someone that you are suspecting to be having COVID or with respiratory symptom, you have to suspect COVID. As you know that this condition is serious, you have to triage the patient and treat or test for COVID. If the test is positive, you have to isolate the patient to continue the care. And it will depend on like his condition. If he unstable, has to stay in treatment center. If stable, you can treat conservatively at home-based care and follow up daily with the community health center or healthcare provider at the nearest home. Thank you. We can keep on.
Thank you, Dr. Thank you, Dr. Poner, for your presentation. While we are waiting your case coming from home with the wife COVID positive, who is now our patient is now suspected. While you are testing the patient, waiting the results, and isolating the please while arriving in the isolation room and taking vital signs, can we have some questions from the audience about testing or screening of cases we are meeting, so that Dr. Joseph will take over, step in after 5 minutes of questions. Thank you.
I can see Richard has raised their hand.
Yes, thank you very much. Can everyone hear me?
Yes, please.
Yes, as you see, my name is Dr. Richard. I work from Kabgai to thank the team that has put forward actually this presentations, which are very, very helpful. And around this at the once doctor just said that in the red zone, everyone should be in PPE. And this comes like being clear to me. If in everyone that he's saying, actually, it means the healthcare providers only or he is including the patients also. And not only that, I have witnessed that in some treatment centers, because they don't provide everything needed to the patient right away, like food, like other primary needs, even they kick in. So I need to know, who really do you mean by saying that in red zone everyone should be in full PPE? Thank you.
Thank you, Richard. I say that maybe I know your treatment center at Kabgai, and I say that this one, because in the red zone, you are with someone who's positive. I emphasize on this, even if you are not in the full PPE or with the PPE, depending on what you are going to do in that red zone, you have to be like protected. And then while coming with that gloves, you have all those PPE, they have to stay in the designed area, because from that area, that red zone, in the green zone, you will be meeting others who are not protected. For example, you go in red zone without any protection. If you go outside and you meet others, it will be easy to contaminate them. We know that even in area where there is patient coughing inside the red zone, there will be those viruses around you. It's why, while coming from the red zone, you have to be sprayed and remove those gloves so that you go in the green zone without virus around you. Thank you. I don't know if I have given a good answer, but that's like the standard of care we have to, or standard of practice you have to do. As we said, on the objective of this presentation is to change our daily practice into evidence-based practice. Thank you.
My concern is, does it concern everyone or only the healthcare providers? That is my question.
I think your concern is very understandable. It's because from our routine practices, as Dr. Poinel was concluding on, Kabwa Treatment Center and other treatment center isolation rooms, we once visited there. Maybe you will be concerned because you may experience some visitors in red zone without wearing the PPE. That is wrong. Frankly saying, that is wrong. So the objective here is to make you understanding the basics of the standards of care we have to do. And if at this time we don't have those basics in standard of care, so work on that to improve the quality services we are providing. Otherwise, you cannot mix someone who is green to a red patient without protecting him. You are causing overspreading of the contagious infection. So that next we may have happy now we are having a strong number of patients, and we may cause the fourth wave if you are not doing the standard precaution of care to your patient in red zone. Please, it's not only healthcare providers, it's everyone who is entering in the red zone. In the red zone has to wear PPE. I think we are clear now on that.
Thank you very much.
Yes, work on it if you don't have. So welcome, Dr. Joseph. Now he's going to talk about what to do when a patient who comes in a consultation after 4 days of dry cough, shivers, living with a wife who is a positive, COVID positive. And now Dr. Poineri has triaged him, has screened him, has tested him, and isolating the patient into the isolation room, where now Dr. Joseph is going to talk on his condition about the oxygen therapy and treating this patient and take care of him. Please, can you take over this case, which we have in your isolation room, and we want you to take care of him.
So thank you very much to everyone. So first of all, I want me. Tell me.
Yes, I can hear you.
Yes,
Okay.
we can hear.
Okay, so thank you. As Dr. Xavier said, I'm Dr. Joseph Nyonzima. So actually, I'm an emergency physician at Rwandan third level referral hospital here at Sashibe. So let's go through hypoxemia and hypoxia. Please go with the next slide. So, okay, here we are. The question here is, what is hypoxia? What is hypoxemia? So, the hypoxemia is referred to a decreased level of oxygen, the partial pressure in the blood, and hypoxia is a decrease of tissue oxygenation. So, at this hypoxemia, it's when the arterial pressure of oxygen is below the baseline of normal values. It means when it's the partial arterial pressure of oxygen is below 60 millimeter of mercury, it's called hypoxemia. And when the oxygen saturation is below 90%, it's called hypoxia. The oxygen transport, usually, a big number of oxygen is transported by hemoglobin, where 99.5% of oxygen is attached on hemoglobin, and 1.5% of oxygen is dissolved into plasma. So it's that the plasma is having a small number of oxygen, and this will implicate in our condition most of our patients who are having low hemoglobin. So at this level, we can conclude that they will have a problem of oxygen transport. So next slide, please. As we told, hypoxemia, it was referred to low oxygen and so, or when someone is having hypoxia, we have a clinical sign for hypoxia detection. First of all, the patient will present to you with short of breath, cyanosis, weakness, even agitation and others. And also for detection, we will need a pulse oximeter. This machine, which will help you to know the level of oxygen saturation at the level of your tissues. Of course, if you have a machine for blood gases, you will get arterial pressure oxygen. So this SpO2, it will indicate your oxygen level, which is bound. This arterial pressure, PaO2, will indicate the oxygen dissolved in your plasma. And this SpO2, it will be a machine, and this partial pressure, it will be a laboratory exam. Let's go on the next slide, please. So let's talk on type of hypoxia. So initially we have, as I told before on the previous slide, where someone has a low hemoglobin, where you will have anemic hypoxia. It means a decrease of hemoglobin level. We need to have anemic hypoxia because of decreased level of your hemoglobin, as hemoglobin is transporting a big number of oxygen. So here you can get an example of anemia. So another one is hypoxemic hypoxia, where there is, hello? Is someone having a question? Okay, no one. So hypoxic hypoxia, it's a decrease of oxygen supply or oxygen source. So for example, when someone is in high altitude or when someone is hyperventilated, types is circulatory hypoxia or ischemic hypoxia, where there is of oxygen delivery to tissues. So for example, in case of heart failure or shock. So the last one will be histotoxic hypoxia. So where tissues or cells are not able to use the present oxygen. So where you can say an example of intoxication, especially metabolic, or where oxygen is bound to other molecules rather than hemoglobin. So let's take the next slide, please. Next, okay. So here, let's see cause of hypoxemia, and it will depend on the type or mechanism as we mentioned above. So let's start from at the alveolar levels. So where you may have hypoventilation, then with your respiratory rate when it's low, there's accumulation of CO2. The low fraction of inspired oxygen, so especially in raw oxygen in your environment. So the next one, let's go at diffusion. So when there is a diffusion impairment, and then there will be impaired oxygen to move from alveoli into the capillaries. And you know those alveoli are located at the lung, and those capillaries are from blood. It means when this transport from lung to alveoli is impaired, so we call the hypoxia from diffusion. So another one, it will be oxygen binding. So as I told you before, this will be ineffective bindings, means oxygen will bind to other molecules rather than hemoglobin. So the fourth one will be ventilation perfusion mismatch. It means between lungs and capillaries, where there is a problem of transport from lungs to capillaries, and here you can get two causes. So the first one, your lungs are getting enough oxygen, but there is not enough blood flow in your capillaries. So this will need to increase perfusion. And when you don't have enough and you enough oxygen in your lungs, this will lead to decrease ventilation perfusion ratio. So the fourth one is a shunt. No shunt for blood circuit will be blood coming from the right side of the heart, then to the lungs where oxygen enter the blood, then it comes back to the heart through the light to the left side of the heart, and then the left side of the heart will distribute it to all peripheral tissues. So if this pathway is disrupted or changed, it will to hypoxia. So we can get an example which is common in our settings, especially pediatrics and neonatology, where we're having cyanotic congenital heart disease. I think you know they are the common, especially in pediatrics. So next slide, please. Next. Okay. So let's talk on pulse oximeter. So as I mentioned above, for detection of hypoxia, we can clinical detection. They can use a pulse oximeter in our can get labs to get arterial blood gases. So here we concentrate on use of pulse oximeter. I think in Rwanda, every health facility is having a pulse oximeter. So in the principle of pulse oximeter working is very easy and understandable. So first of all, the pulse oximeter, it uses two kinds of light. First of all, it's a LED light and infrared light. Those are different. And then based on mechanism of absorption of those two kinds of light. So oxygenated blood, oxygenated hemoglobin will absorb more infrared light, then allow more red light to pass through. It means it will absorb one light and make other light to move. And the whole oxygenated hemoglobin will absorb more red light and allow more infrared light to pass through. It means, in summary, oxygenated hemoglobin will absorb one light and allow other light to pass. And the oxygenated hemoglobin will allow other light to pass and then absorb other red light to pass. So this was a mnemonic said 6 daring. So it means 600 wavelength. It means those light will make more wavelength, and then the oxygenated hemoglobin will absorb red light, and then we will get a curve with real number of this oxygenated hemoglobin, and we will call it SpO2. Next, please. So pulse oximetry physiology. So this is the machine we are familiar with it. So it's the machine who's having a probe where we are inserting our finger, and the monitor where we are getting our result, so our number of SpO2. So the patient must have a pulse for the probe to pick up a signal. So why we need the pulse before using this SpO2? Just is very simple, because here when you have pulse, it means your blood is moving, and when your blood is moving, it's where we get oxygenated hemoglobin. So if your blood is not moving, you can't get oxygenated hemoglobin. So another issue what I want to mention here, most people, they are taking this machine, immediately they're putting in the finger, then they get the first number. So this is coming without a regular curve. This is not a true SpO2. To get a normal SpO2, you have to see this curve below those number. There is a curve which must be regular and to your screen or your monitor. so that you can show you are catching your oxygenated hemoglobin, and then you can read. It means just don't read the first number coming to your monitor just without a normal curves. Next, please. So as you are doing in our daily clinical activities, pulse oximeter interpretation is simple. Just our target is to get the normal SpO2, which is above 90%. And you know the normal range of SpO2. So it's above 90, and the abnormal is below 90. So I think we are familiar with this one. We don't rely on it. Next, please. So here there is the chart where the light box triage. So it was created in case of COVID-19 response. So it if we from RBC by using a pulse oximeter, and to determine when oxygen support is needed. So it was created to help frontline providers, especially people who were in COVID management initially. So in a low resource setting, this was very, very useful to give to the patient this pulse oximeter. So then you tell them those clinical symptom which someone might experience at home, and then tell him if we have those symptoms and then have SpO2 which is below 19. So make sure you have to consult the clinic or you call the command post. So really it was, I think even today is helpful in people with COVID. If you have it at home, you are sure that if you have the symptoms and you have your pulse ox, when you have a normal values, usually regarding on this chart, you will consult a doctor. If a doctor also use this and see you need a transfer to the treatment center. Next slide, please. So yeah, here on, let's talk a little bit on non-invasive therapy. But is really a medication which is important, also which is helping people in COVID-19. So later we will see the oxygen delivery device to use. I think also everyone is familiar with them. So let's talk on non-invasive ventilator oxygen therapy. Since hypoxemia involves low blood oxygen levels, the main of treatment is to try to raise blood oxygen level back to normal. That's the first way to correct hypoxia. If an underlying condition is causing hypoxemia, treat that condition as well. So it means here we have the two goals. First of all, someone's having hypoxia, just give supplemental oxygen. The next one, try to search the cause of that hypoxemia and treat it. If you don't correct the condition, the hypoxia will persist until you discover the initial cause. Next slide. As I told, oxygen delivery device. So most of them we are familiar with. So the first one you are having is a nasal cannula. So this nasal cannula is having two small probe, what you are inserting them in the nostril. So we know all of them pediatrics and adult, and those nasal cannula are delivering oxygen at a flow from 1 to 5 liters per minute. And those nasal cannula are expected to give us the FiO2, fraction of inspired oxygen between 21 to 40. So why 21? Because below FiO2 below 21, you know, it's a Lumea FiO2. So the second one is a nasopharyngeal catheter. So this one can administer a small amount of oxygen from 1 to 2 liters by minute, and it can administer a high FiO2 from 45 to 60%. The third one is a simple facial mask, and you know everyone is familiar with that. It can deliver between 6 to 10 liters by minute, and with FiO2 of from 44 to 60%. The fourth one is mask with reservoir. It will administer a flow from 10 to 15 liters per minute. It can administer FiO2 above the 60%. So the last one will be a Venturi mask, which can administer up to 15 liters by minute. It's having different size and can give FiO2 from 24 up to 60. So I think we are familiar with those one, nasal cannula. I think everyone in Rwanda in health system is able to use a nasal cannula, and they will know it. So don't use a nasal cannula and give more than 5 liters per minute. That will be a loss of a misuse of our resource, because from 5 above, nasal cannula can't support it. So we are not usually with nasopharyngeal catheter. Probably some institutions don't have it. So, but with simple facial mask, we will have it, which can be used to give between 6 to 10 liters. And mask with reservoir where someone is above 10 to 15. So our oxygen regulator in Rwanda, most of them are between up to 15 liters per minute. Please, you are not very well to know which amount to give. Don't give a patient a 10 liter and put a nasal cannula. Don't give a patient 15 and give a simple facial mask. Just try to adjust according to your flow you are giving. So another issue what I want to insist. So normally those are done, are supposed to be a single use delivery device, and you have it once, then when you come back with another one. So but in case of low settings where you don't have enough materials, so those devices are cleaned, disinfected in appropriate solution, I think, right, in our condition, and then can be used in the future. Maybe in a discussion, you will give us your experience at different hospitals. We will discuss more if we have another method of keeping this. So next, please. So let's talk a little bit on non-invasive pressure ventilation. So we are calling this non-invasive pressure ventilation because by this ventilation, we are not entering the human body, just reducing the face to produce a pressure air into the lungs. So at this one, it provides a positive pressure ventilation to support the patient spontaneous breathing. And we need a inspiratory pressure and inspiratory positive airway pressure, which will be set the patient with IPAP. Then we are with a small pressure for expiratory. It means we see the patient to get in a good pressure. Then also we help the patient to make out during expiration with a low pressure. So this will help the patient to expand his alveoli and get more space for oxygenation, because the good ventilation end up with good oxygenation. Next, please. So during non-invasive pressure ventilation equipment, we will need a BiPAP machine. This is the machine which will be used, as I told, in inspiratory pressure and expiratory pressure. And we call it bi-level. It means 2-level. Inspiration and expiration. We are giving pressure at both times, but small pressure in expiration. Also, we need a circuit, disposable circuit with proximal pressure line and exhalation port. It means we give the circuit, will allow in and out. So we need a bacteria filter, especially for bacteria or when the patient is having, secretions. We don't want to save those bacteria in our machine. So we need a filter. So we need a full face mask. The mask which can cover the whole face, or those are also in pediatrics, nasal mask, which are doing a CPAP machine in pediatrics. We need a humidifier to give the humidified air to avoid dryness of the airways. This will be mixed with distilled water. Also, we need duodenum for pressure sores prevention. As long as you apply a mask with the patient face, so make sure those are not causing pressure, like impaired peripheral circulation. Next, please. So let's end by some complication which may come from oxygen therapy or non-invasive pressure ventilation. So for oxygenation, so the FiO2, to make a patient to give a supplement oxygen of 100%, so it can harm the patient by tracheobronchitis, and decrease the vital capacity of the lungs. Also, like oxygen side effect as a medication, it's produce free radical, and which is damage brain cells that the patient can deteriorate. So the safe side of hypoxia would be better to start by 60%. Then you start with the patient from oxygen every day. If the patient is stable on 10 liter, try to make it on 8, next day on 5, then that's good, the winning. Then remember that oxygen is a medical prescription. Just give oxygen, give a device to use, amount to use, and suggest when the patient will consume it. So another one on non-invasive pressure ventilation as a complication. So as you are applying external pressure, so you may cause a cardiovascular compromise. So you can break the skin of the patient. Go that really prevent pressure sores. So as you are inflating the gastric with that pressure, so the patient may get aspiration of gastric content. So can cause a barotrauma. It means you are inserting more pressure. So the patient may have a sputum retention because of pushing. So of course, the patient may have respiratory fatigue or failure. So as long as the patient is not improving well. So the first, to give non-invasive pressure ventilation, so make sure a patient is not vomiting, and make sure your patient is fully awake or is collaborating. So otherwise, if you give the non-invasive pressure ventilation, the patient who is unconscious, for sure you will harm more than treating him. So thank you very much. That was my presentation.
Thanks, Dr. Joseph, for your presentation. Our patient has deteriorated. We sent him to you in isolation room. You gave oxygen and you recommended to give appropriate oxygen as needed with the appropriate oxygen delivery device. There is some question asked in the chat. which has been asked, like how then can you really clinically differentiate hypoxia from a medical condition versus hypoxia from internal bleeding? That is a question asked during the presentation. If you have some comment, please, welcome.
Okay, so thank you for this question. Is asking how really clinically differentiate hypoxia from a medical condition versus hypoxia from internal bleed. That's a good question and need the science. So initially, hypoxia is hypoxia for sure. So then, in the case of a medical condition, as I told you before, our patients are being examined. We have a history and you have clinical signs and symptoms. First of all, if the patient is healthy before and he got an accident and he come to you with hypoxia, start to think in that history, that the patient might have internal bleed. Because that's not a medical condition, it's a trauma condition. So another one, you will do your physical examination from head to toe. If your patient is having short of breath, agitation, cyanosis, weakness, so hypoxia is hypoxia. And as I said, the detection is clinical presentation, SpO2 and the labs. If in our physical exam, our patient is having those features of trauma, just call it hypoxia if internal bleed. If it's coming from a medical condition, of course, after your physical examination, just we will call it. So I think really here is to know what the patient was examined after getting a clear history, and then we will know really which kind of hypoxia.
Yeah, good.
That's all.
Good, good. And also he can refer to the algorithm where we show the types of hypoxia and the causes of hypoxemia. He may have some orientation to differentiation trends. As you said, the trauma hypoxia, he may be losing blood, he may be having many things from the causes we discussed into hypoxemia and hypoxia. Thank you. The audience still have some minutes to ask questions to Dr. Joseph regarding his presentation. Feel free in any language, please.
Even in Rwanda?
Yes.
Okay.
We want people to understand what you are delivering. We will translate for the where needed.
Right. Okay. Okay, there is a question here from Dr. Sam. Imagine that you accidentally cause a ballot trauma during delivery. So this will be non-invasive where you can get ballot trauma. And what proper approach for this patient? So this is a good question. This is a good question. So this is a complication of treatment. So if you cause a ballot trauma as a side effect, so the plan, of course, you will reassess your patient by support your patient because already alveoli are no longer working. So really, there is no but of course, we will open the patient mouth. Of course, you will stop that non-invasive ventilation. And then you will need also nasal decongestant, like antihistamine for that patient. Of course, after stopping that non-invasive ventilation, you will stop like a diving descent of the first sign. So it means which sign the patient will present. You will learn that sign and collect it. And not only barotrauma, also trauma. Also trauma, it will be the same. You will stop and then you will start supportive treatment. So only medication you can give in the case of barotrauma, give an anti-inflammatory medicine, decongestant, and a strong painkiller, and then you support your patient. Otherwise, the rest will be supportive.
Yeah,
I think I got the answer.
Thank you. The question causing barotrauma or causing trauma, we lead to what we call commonly the pneumothorax. You are leading to pneumothorax, and that pneumothorax will be surgically managed by putting chest tube to remove that air which has been pressed into the chest, so that the chest tube, you may relieve the patient and keep other supportive therapy to that patient. Okay, I think, any other question? So we are almost the end of our first session on considerations of triage. Before I go to take-home messages, I have something I want to ask to the audience for this first ever meeting we had. What do you think we can change to improve our session? Because we still have 11 sessions. We need your input, your comments, so that we can do more in terms of methodology, content, or interaction. Second, do you think this discussion is irrelevant to your setting where you work? Just those two questions you can put in the chat. You can raise your hand and feel free to express in any language, even Chinese. Thank you.
So thank you, Xavier. Let me start because I'm about to leave. Just the general comment. So initially, I will thank our team in the South Province, especially those hospitals around Sashibe. For sure, I'm happy for my team. Of course, we got a challenge of network in our conditions. Some people are messaging us saying that we are not able to join. Some people, it was a network errors. So also during the presentation, we got some kind of internet issues. I don't know if it was on our side or the organizer. So maybe next time it can be collected. Also on our side, of course, we try to get Zoom on our device, phone, computers, or whatever, so that the maximum number can attend. So I think,
thank you. The maximum number can attend. Now we are having 70, but I think there are some who shared their devices. We may be communicated and can be more on this 70 we are having, if there are some who share the devices. We are having 3 people with raised hand. Let's start from Uwamahoro. Welcome.
Thank you. The presentation was very, very interesting, but we had some issues of networks. Maybe at the next time you will correct it. But the presentation is it was very, very interesting for us. Thank you.
Welcome. Thank you. Yes, Richard. Richard. Dr. Richard.
Yego murakoze, sinzi niba muri kunywa.
Yego turakumva. Turakumva Richard.
Can you mute your...
So while we're waiting...
Hello?
Yego?
Yego, nari mvuze nti nk'uko wari utubajije mu bibazo bibiri, gishobora kuba gisa nk'aho kibangamye, mu by'ukuri gishobora kuba cyarebwaho niba cyahindurwa cyangwa se cyakosorwa, ni amasaha gutangira saa munani. Mu by'ukuri abitabiriye twese dukora mu bitaro, ayo masaha ntabwo mu by'ukuri twese tuba twakabaye fully available ku buryo umuntu yakwakira discussion nziza nk'iyi ngiyi igamije kugira ikintu kinini twigisha, cyane cyane no mu mikorere yacu ya buri munsi. Atangiye saa munani hari byinshi umuntu aba atari yashyira ku murongo, cyane cyane mu byo dukora mu bitaro. Ubwo rero njye nk'icyifuzo, wenda izi discussion sinzi niba bishoboka zisunitswe zikagezwa saa 11 Central African Time, tukaba ari bwo wenda dutangira iyi saha imwe cyangwa amasaha abiri tumara tukayamara, ariko nyine twatangiye mu masaha mu by'ukuri bigaragara ko tutari bibi, cyangwa se saa 10 nta pepe tutari ku saa munani aba kitabira. Hanyuma cyo kubaza niba mu by'ukuri biri relevant mu ibitaro dukoramo, relevant cyane kuko COVID-19 by'umwihariko ibitaro ahantu hose dukorera nta bitari iyo oxygen delivery twize, nta hantu tudakenera oxygen delivery to our patient. Triage nta tudakenera triage. So mu by'ukuri amasomo yose turi kwiga ari relevant kandi dukomeje kubashimira cyane. Murakoze cyane.
Urakoze nawe. Yeah, turabirebaho kubera we are having thank you for your comment. The discussion is relevant to your setting, and also you talk about the challenge of time. 2 to 4 p.m. Is maybe not feasible to people who are in their work. We'll consider many factors, including our partners into USA. This time I think they are in the early morning, so we'll try to consider everywhere, and we have some in India also. So putting it together, we may resolve this after we discuss. And I think the question, also the comment is relevant to, we need our attendance to be more, and also to apply what we are learning and discussing into our settings. There is Marie Claire. If you have also a comment, please welcome.
Murakoze, sinzi niba muri kunyumva.
Turakumva.
Mwakoze kutwigisha, ndashimira abatwigisha batanze presentation, mwagerageje gusobanura neza, twabyumvise. Hanyuma kuri iki kibazo cy'amasaha mugenzi wanjye yavuze, nakomantaho gakeya. Ari amasaha avuze kuva saa 10 kugera saa 11 cyangwa saa 12, hari abo bitakorohereza cyane kuko hari abava mu kazi tujya no mu yindi mirimo yo mu rugo, nk'ababyeyi tuba dufite inshingano nyinshi. Kuri gihe wari amasaha ntacyo atwaye, ariko nanone bitabuza ko abenshi bafasha amasaha saa 10 ntago byatubuza none kwatendinga. Hanyuma igihe cyo nashaka kubasaba, nk'uko tuba turi mu kazi turi gukora, ntago ari twese tubasha kwitabira neza 100% iyi meeting kuri Zoom. Nasabaga niba byashobokaga buri presentation mwatanze na mwazajya muduha soft kuri email, umuntu agasubira akaza kunyuzamo amazi. Murakoze.
Thanks Marie Claire. As I said, regarding the time adjustment, we will put into consideration many factors which will help our audience to be available. And regarding also the presentation, this will be shared to you via our group. We have our different groups. We have our general group of this program. So that, don't worry, we'll share this presentation to you. So if there is no other comment, please, let's make the minutes which left, share with you some communique. This was our first session. It was our launch ceremony. I am thankful to everyone who participated. I'm thankful to my hub team, Dr. Pauline, Dr. Joseph, Dr. Venice, and Madame Liberata for their time and their preparation. There was a good slide presented. The next time we are having this, we are having on 3rd November, the time we will show in our posters after discussion, and we will be discussing on hypoxia also. And then what I want to tell is just a take-home message from this presentation. We have to understand that we have to set up in our health facilities triage screening areas, and also take measures, IPC measures for all contagious infectious disease. And where we don't have, please talk to our leadership to see where we can improve our IPC measures in our hospitals or health centers. Second, be familiar with donning and doffing a PPE, either for COVID, Ebola. I had information that in DRC now they have some cases. So please take care of yourself, protect your families, and don't negligent to wear PPE when you are having a contagious case. Second, third, you have the screening of COVID patients at any time. This time we may say that we don't have big number. Our positivity rate is now less than 1%, but please, the COVID stay there. Screen all patients who comes with symptoms, as we said, or with suspected. Have a triage protocol to your hospital. Have isolation areas, and then whoever is in that isolation have to take precaution. The big and important thing, you have to recognize hypoxemia and the causes of hypoxia and hypoxemia, because without oxygen, the body is working in an aerobic field, so that an aerobic body will cause, or the cell death. So that early recognition of hypoxia, hypoxemia is very important by using pulse oximeter correctly, as Dr. Joseph insisted on. Please don't read and report a number. Look at the two things, the number and also the pulse wave regularity. Be familiar to treat hypoxia, treat with oxygen at the dose responding to the patient's needs, also by using the correct delivery devices without wasting the less oxygen we are having. Thank you. That was what I have to tell, and hope to meet you in next 2 weeks, where we'll be talking about deeply diagnosing hypoxia and hypoxemia. So please, you can also join our next session on 3rd November. We'll be discussing of diagnosing hypoxemia with the pulse oximetry. And if you have any question, we are having a general WhatsApp group. You can also email to the echo@assistinternational.org. And also having visit our running resource center from Stanford University, which we shared with you in our different group. I'm thanking also to the team in USA, in America at this time, and I'm thankful to the team in India. And to me, my time is over. Hope to meet you next.
Thank you, Dr. Francois. Thank you, everyone. Dr. Francois has already taken the housekeeping slides conclusion. Like you rightly said, if next session is on November 3rd, 2020, it's a bi-weekly session. And then if you have questions, kindly email us at echo@assistinternational.org. We also have a WhatsApp group. The WhatsApp link has been dropped on the chat box. Kindly join for the WhatsApp group, please. Thank you, everyone, and see you next time.
See you.
I would like to encourage all participants to encourage others also to join next time. If they didn't join, to join next time. Thank you.